Good afternoon, everyone. First of all, I thank Dr. Srinivas Kumar sir and team for making me a part of this scientific program. Sir has always been enthusiastic about collaborating with the concerned departments about extending therapies for the welfare of patients. So it's a good initiative, and I'm happy to be a part of this program. How many of you encounter either patients or family friends asking you about opinions on stroke, thinking it is heart attack or heart stroke? Have you encountered patients or family members? Because people keep asking me about, am I heart attack? So it's always nice to know about heart stroke as well. So I'll keep the talk very basic. So I'll start off with case scenarios. 66-year-old diabetic hypertensive with sudden onset weakness, right upper and lower limb, and inability to speak, with gaze preference, and the time of onset of symptoms is 2 hours. A second scenario, same age group, similar comorbidities, same clinical presentation, but 4.5 hours since the time of onset of symptoms. Another scenario, similar age group, same comorbidities, same clinical presentation, but the time of onset of stroke is not known. The patient was seen last normal before going to bed at 10 p.m. and he woke up. He was not woken up. He was found at 5:30 a.m. in a drowsy state, inability to speak, weakness of the right half of the body. Another scenario, young patient, no medical comorbidities, similar clinical presentation, but 2 hours since the onset of symptoms, but he had a surgery 14 days back for an anterior cruciate ligament tear. A last scenario, a 70-year-old female, similar comorbidities, same clinical presentation. Again, the time frame is 7 hours from the onset of symptoms, but she had a background history of atrial fibrillation for which she is on and novel anticoagulants. So these are different clinical presentations. So my lecture is outlined this way. What most of us or some of us are familiar with in terms of stroke. Secondly, how things have evolved. The guidelines have evolved, the concept have evolved in the last few decade or so. And finally, what is a pathway for an acute ischemic stroke? So most of us right from our undergraduate days are familiar with the symptoms of stroke, both the anterior circulation and posterior circulation stroke. 85% of strokes are ischemic strokes, and if identified appropriately, can be treated appropriately and neurological deficits can be reversed. Like time is a brain concept is a very familiar concept because with the passage of time, it is known that several neurons die, and when neurons die, they are usually irreversible death. So time is very crucial for intervention. The treatment options would be either broadly medical or endovascular. Medical, again, depends on the time of presentation, whether it is just antiplatelet medication or is a role for thrombolysis or not. Sometimes thrombolysis is bridged with endovascular therapy, which has been found to be effective for endovascular stroke treatment. It is very well known since 2015 with the trials that endovascular therapy definitely has a role in the treatment of acute ischemic stroke, but the case selection is very important. It has been found that the number needed to treat to to prevent one functionally dependent outcome is 5.4, which is much better than the percutaneous coronary interventions. And it doubles the rate of good neurological outcomes, and it reduces the mortality by almost half. So the interventions are talked in the next lecture. So thrombolysis for acute stroke from 1990s has been going on, and with a lot of data available, it needed refinement of data to categorize patients into who is apt and how to extend time frames. So with all the available data, it was found that some patients do well with thrombolysis, some patients may not do well with thrombolysis. Similarly, with interventions, some people do well, whereas others don't do well. So studying all the data, it was found that the three important factors which determine the outcomes are classified as 3 C's. The first C is the core. Core means the ischemic core or the dead tissue, and how much of surrounding tissue can be salvaged, which is the ischemic penumbra. Second thing is the collaterals. Brain has got amazing amount of collaterals, which vary from person to person. In fact, if stroke was there and you don't treat it, 20% of them recover spontaneously because of the natural mechanisms in the body, which are fibrin lytic mechanisms, as well as the collaterals which sustain. And sometimes you do an angiogram for chronic occlusions, you see that the whole brain is being supplied by a single vessel, and it is sustaining based on that single vessel. So it is not just the timing of stroke, but how slowly or it has evolved over a period of time, which determines how the brain has got capacity to tolerate that ischemic insult. And third thing is the clot burden. So let's understand this ischemic core concept. Suppose this is a internal cerebral artery, the middle cerebral artery, and the anterior cerebral artery. There's a block. This black color thing is the block over here. So this area is at risk, a maximum risk. And the area which is slightly pinkish over here, it is determined, the tissue over here is determined by the collaterals, which are supplied either from the anterior circulation or posterior circulation. And we know that the normal blood flow to the brain is around 50 ml per hour. And as the blood flow decreases, there is an electrophysiological failure. And finally, there is a metabolic failure at the cellular level. And only then it becomes an infarcted tissue. So the center core cannot be reversed, whereas the surrounding penumbra can be salvaged. But the question is, how do we identify this surrounding penumbra? We have to image the brain. And all of us know that there are two imaging modalities for the brain. One is the MR, the other one is the CT scan. CT scan, if there is a black tissue on CT scan, it is well understood that that tissue cannot be salvaged. So it is dead tissue and that cannot be reversed. If you see the MRI, if you look at any MRI brain, there are so many sequences. Now, each sequence is a particular information to give us. And third thing is the angiogram. We cannot do angiogram in every facility. So, but this is to explain the ischemic core concept. If you see here, in both the cases, the middle cerebral artery is occluded over here. In the first scenario, the patient A has got a good collateral flow with the anterior cerebral artery supplying up till this territory. Whereas the second patient, the anterior cerebral artery is not able to supply this territory and it has got a poor collaterals. So definitely we know that patient A has got a better chance of improvement following revascularization therapy when compared to patient B. But like I said, we cannot treat every patient with do an angiogram for every patient. So these trials, 2015, was the year when neurointervention for ischemic stroke became very popular. But thereafterwards, the following trials, 2017, the DAWN trial and the DIFFUSE trial, made use of these techniques to identify which patient is at risk and which can be salvaged brain tissue. If you see the investigations available, the metabolic investigation in terms of measuring the cerebral blood flow with a PET scan is the ideal test to identify which tissue can be salvaged. But in an emergency situation, we cannot do PET scans for every patient. So what are the other options available? We have a CT scan and an MRI. So when we do a CT scan, it is always recommended for a stroke patient that it is followed by a CT angio and a CT perfusion study, because that will tell us how much of area is already infarcted and how much of area can be salvaged. I won't go into the finer details, but that is based on the cerebral blood flow, the cerebral blood volume, and the mean time to transit that particular area. These are the parameters used in the CT perfusion. Whereas an MRI, in the MRI, acute stroke is identified on the diffusion MRI scan. A diffusion MRI scan shows that, let's say this is the diffusion MRI. Diffusion MRI shows that there is a white spot. That means that is the area of stroke. Now, there is another sequence called the flare sequence. If you see a bright spot on the diffusion MRI, and if you don't see that bright spot in the flare scan, that means it is a salvageable tissue. On the other hand, if you see both the diffusion and flare showing the same amount of intensity changes, the same territory, that means it is an irreversible damage which has happened. So this is one way of identifying whether the tissue can be salvaged or not, apart from the CT perfusion parameters. The second thing is the same MRI can be used in the form of a perfusion MRI, and the perfusion study will give us which territory is at risk and which territory is not at risk. Each of these two investigations, a CT-based protocol or an MR-based protocol, have their own advantages and disadvantages, but we will not go into the finer aspects of that, which institute has got their own pathway depending upon the available resources. Both are equally good options. Whereas a posterior circulation stroke is better made out on the MRI, unlike a anterior circulation stroke, and that is where clinical examination comes into picture when you order an investigation. So this is a CT perfusion image, which will give so much of information about which area is blocked and what is the cerebral blood flow to that area, what is the volume in that territory, and what is the time taken to travel to that area of block, and so on. Because in the middle of the night, these things are difficult to interpret because you need a radiologist who can sit and analyze all these parameters. Similarly, a technician should be able to follow the correct protocol. Now we have the artificial intelligence. There are softwares available where the technician just needs to follow the method of doing an angiogram right from the aortic arch to the neck and intracranial circulation. And thereafter, within 10 minutes, the message will come to the operator or the radiologist about how much of brain tissue can be salvaged. So these are the artificial intelligence software most commonly available, is used as the rapid software. So that a patient comes to the ER, the imaging is done in 10 minutes, you get a reply after the imaging as to how much of tissue can be salvaged and how much of tissue is already dead, based on which you can proceed with the either the thrombolysis or the endovascular treatment. Now, thrombolysis, as we know in stroke, is extended from 3 hours to 4.5 hours. And thereafterwards, it was even studied up to 9 hours, because based on these perfusion images, if there was found to be a tissue which can be salvaged, why do only thrombectomy? Why not we do thrombolysis in these patients beyond the 4.5 hour window period? So this trial studied the thrombolysis up to 9 hours. Although there was found to be no or minimal clinical outcome, it was found that the hemorrhagic complications were found to be alarming in these patients beyond 4.5 hours. So beyond 4.5 hours, it is a case-to-case decision based on the experience and the interaction with the patient's family, whether to proceed with thrombolysis or not. There is another trial which has been studied thereafter, which studied endovascular treatment alone. Why do thrombolysis if you know that there's a large vessel blocked and you know that thrombectomy is going to work? Why at all do thrombolysis? So this has been, in this trial, they have found that only mechanical thrombectomy without thrombolysis is non-inferior. So it is a non-inferiority trial, like we had the carotid stenting non-inferior to endarterectomy. Maybe in future, if you have a patient who is going to a hospital and there's a large vessel occlusion which is found, maybe the future would be to directly shift the patient to cath lab in a tertiary care center where all facilities are available if the timing is appropriate. So as we know, the heart and brain don't like delays, but how much delay is enough for the brain to tolerate or not tolerate is a question. So that is why pathways are being created. Pathways help us guide even a novel person or a patient who is new to kind of follow a protocol, or a person who is in the emergency to follow a protocol about how to go about and what are the timings to be followed. See, the ideal timing is within 60 minutes from the time of onset of, arrival of patient to the emergency. The workup, the clinical evaluation, the workup, and the thrombolysis have to be done. And because you have a time window of up to 6 hours, doesn't mean that you can wait for the last minute for the patient to go to the cath lab. The idea is to push the patient after immediate thrombolysis as early as possible to the cath lab. Now, the clinical examination is a little bit cumbersome. If you see the criteria, most of them use the NIHS scale criteria. And if you look at the scale, it's so complicated. These scales are available in the ER, but if you have to do a rapid assessment, you see that it's practically a little bit challenging. So the simplest way is a patient who has got a gaze preference to one side, which indicates that the major vessel is blocked. Similarly, if a patient has got aphasia with weakness on one half of the body, that also indicates that a major vessel is blocked. Similarly, if a patient is not able to hold the hand in the air for 10 seconds or leg in the air for 5 seconds, that means it is a major stroke. So these are simple thumb rules which can guide you whether a patient has got a major stroke or not. It's not necessarily in the tertiary care center. These simple tips are important in the peripheral centers where NIHS scales are very difficult to implement. So that is where the awareness is important about just 4 or 5 parameters clinically, what you can see and what next investigation to do to save the patient from undergoing a permanent brain damage. So this is important because we know that up to 4.5 hours, thrombolysis can be done. 6 hours used to be the cutoff for mechanical thrombectomy, but with the availability of the advanced imaging modalities like the perfusion imaging, the MRI and CT perfusion images, and the softwares which can deliver the report within 10 minutes without the need for a radiologist, that time window has been extended up to 24 hours. What if the patient is in a periphery center? If the peripheral center, if you identify a stroke, start the thrombolysis, which is called a drip, ship, and grip. So drip, the thrombolysis drip is started or a bolus is started in the periphery. The patient is being shifted to the nearest tertiary care center or a comprehensive stroke center. A pre-notification is very important in such patients because you can always keep the cath lab or ready or the staff ready, and then grip the clot is an effective strategy which is described for these interventions. So this is the final pathway. Less than 4.5 hours, CT or CT angiogram for the anterior circulation. For a posterior circulation, an MRI is a better option. Fulfills the criteria for thrombolysis. There are so many exclusion criteria. I'm sure the exclusion criteria will be similar for the heart as well. Go ahead with the thrombolysis. Again, tenecteplase versus arteplase, there is no difference. Many people are moving towards tenecteplase for the because of the effective thrombolysis, less complications, and less cost involved. If there is a large vessel occlusion involved, then endovascular therapy may be used as a bridging protocol. If the time window is between 4.5 to 24 hours, or if the onset of stroke is not known, for example, it's a wake-up stroke, then it is compulsory to do a particular imaging protocol to see the salvageable tissue, which is based on the CT perfusion or the MR perfusion. And you can either take the help of a radiologist or use the artificial intelligence software, and then go ahead either with thrombolysis. Thrombolysis is of no role beyond 24 hours. So the only option available is endovascular therapy. More than 24 hours, usually the brain is infarcted in almost all cases. So it's only medical therapy or watch anti-edema measures and decompressive craniotomy were indicated. Very rarely, if the patient was lucky enough to have good collaterals, then you can assess the salvageable tissue or do an imaging to look for any stenosis which can precipitate another episode of stroke, and you can correct that. There are some special situations like stroke thrombolysis in the 3 to 4.5 hour window where the age is more than 80 years. Oral anticoagulants are being used. A patient has got a severe stroke or a combination of ischemic stroke and diabetes, which are controversial topics, so I will not be touching about it. Similarly, patients who are on anticoagulants, whether to reverse it before anticoagulation or not is a question before thrombolysis, but that's not a contraindication for endovascular therapy. Similarly, posterior circulation stroke is a totally different ballgame. The criteria are totally different. On a case-to-case basis, one needs to decide. Similarly, the endovascular therapy for medial vessel occlusions, I think next speaker will be talking about it. So to conclude, at the end of the, though it's sort of a busy slides and a lot of things, who is eligible for thrombectomy, the thrombolysis, any patient who has got a salvageable brain tissue, no hemorrhage on CT scan within the first 4.5 hours is eligible for thrombolysis. And thrombectomy patient up to 24 hours, depending on how much of tissue can be salvaged. Available techniques I have described. Success rate with thrombolysis alone is around 40%, whereas if you bridge it with mechanical thrombectomy, it can go up to 80%. And this has to be explained to the patient that success rate, I mean, is not just opening up the vessel, because recovery takes up to 90 days. So when we talk about success in stroke interventions, we talk about the 90-day period of either functional recovery at the end of 90 days. Thanks for the opportunity.